Hi, my name is Michelle Armstrong. I'm a registered nurse and licensed professional counselor certified by the National Board for Counselor Certification, and I will be presenting an episodic SOAP note video presentation on the topic of streptococcal pharyngitis. The patient in this scenario presented with a chief complaint of "my glands feel swollen." The patient was a 22-year-old white male in a usual state of good health until 2 days ago. The patient complained of acute onset swollen and tender glands in his neck, sore throat, fever, headache, and malaise. The patient denied chills and sweats, watery, sticky, or irritated eyes, sinus discomfort, ear pain, cough, stuffy or runny nose, sneezing, ulcerative stomatitis, hoarseness, abdominal pain, nausea and vomiting, diarrhea, vesicles and ulcers on the palms of his hands and the soles of his feet, and a rash. The patient stated that his swelling, tenderness, soreness, fever, and headache seemed pretty constant and were intensifying. The patient also stated that his glandular discomfort and throat soreness were worse in the morning, with fever, headache, and malaise worsening as the day progressed. The patient denied radiation of glandular or pharyngeal pain or headache. He stated that his throat discomfort was aggravated with swallowing but relieved by sucking on Jolly Ranchers and cough drops, drinking nectar, gargling with salt water, and running a humidifier. The patient reported that ibuprofen relieved his fever and headache and rest his malaise. The patient stated further that he babysat his 5-year-old nephew 2 days ago and that the nephew had just been diagnosed with strep throat. During a review of systems, the patient reported that he had fever and malaise. He denied recent weight changes, chills, sweats, weakness, and fatigue. The patient denied having vesicles or ulcers on the palms of his hand or the soles of his feet and denied having a rash. The patient reported having a headache but denied excessive tearing, ocular discharge, and irritation, as well as earache, ear infection, or ear discharge. The patient also denied having frequent colds, nasal congestion, or discharge. He denied sneezing and sinus trouble. The patient did report having a sore throat and dysphagia, but denied having ulcerative stomatitis and hoarseness. The patient reported having swollen tender glands. The patient also denied having cough, dyspnea, and wheezing. The patient denied having heart trouble, high blood pressure, rheumatic fever, heart murmurs, chest pain, or discomfort. He did again report having dysphagia, but did deny anorexia, nausea, vomiting, and diarrhea, as well as periumbilical pain. The patient denied jaundice and also denied splenic or liver discomfort. The patient denied joint, muscle, or body aches, and he denied having scapular and back pain. The patient had denied a history of depression or treatment for other psychiatric conditions and did affirm that he did indeed have a headache. The patient's active medical problems include complaints of acute onset swollen and tender glands in his neck, as noted in his history of present illness, as well as the presence of a sore throat, fever, headache, and malaise. The patient denied chills and sweats, watery, sticky, or irritated eyes, sinus discomfort, ear pain, cough, stuffy or runny nose, sneezing, ulcerative stomatitis, hoarseness, abdominal pain, nausea and vomiting, as well as diarrhea and the presence of vesicles or ulcers on the palms of his hands and the soles of his feet. The patient further denied having had a rash. The patient's past medical history was negative for scarlet or rheumatic fever or chronic childhood illnesses. The patient denied having chronic medical diseases as an adult and denied having had surgeries or having received any psychiatric diagnoses. The patient did state that he was taking ibuprofen 200 milligrams by mouth about every 6 hours and that he had been taking that for the past 2 days. The patient denied use of other medications, home remedies, vitamins, minerals, or supplements, and said that he had no known drug allergies. The patient states that he has received all of his childhood immunizations and that he had received a flu vaccine in November of 2016. The patient stated that he had received no other immunizations, but that he he had had a negative tuberculin screening in October of 2016. The patient has denied a family history of headache or rheumatic fever, but did note that he is single and not in a relationship. The patient said that he is a pre-medical student, not sexually active, and he denied having a history of sexual activity. The patient stated that he was employed as a restaurant host and that he also worked as a hospice volunteer. The patient denied the use of tobacco, alcohol, and recreational drugs, and also denied the presence of any mental health diagnosis or mental health challenges. The patient did state that he wore a seatbelt. During a physical exam, the following were noted. The patient's vital signs were 120/80 with a pulse of 75, respirations at 16, and a temperature of 102.5. The patient's height was 5'9". He weighed 140 pounds and had a BMI of 20.7. The patient was well-developed, well-nourished, but ill-appearing. He was clean, kempt, and appropriately attired with a definite streptococcal tonsillitic odor to his breath. He was cooperative as well as awake, alert, and oriented ×3. The patient's skin was flushed and moist, but he had no vesicles or ulcers on the palms of his hand or the soles of his feet. He did not have a rash, nor did he have jaundice, signs of jaundice. No abnormalities were noted in his head during the physical exam, during a physical exam of the patient's head. No conjunctivitis, excessive tearing, or discharge were noted. During an examination of the patient's auricle, canal, and eardrums, no abnormalities were noted, nor was discharge in the ears noted. The patient's nasal mucosa, septum, and turbinates were without abnormalities. No discharge or sneezing was noted during a nasal and sinus exam, and the patient denied frontal and maxillary tenderness during that exam as well. The patient's lips, oral mucosa, gums, and tongue were without ulcers. Palatal petechiae were noted, as well as enlarged edematous beefy red tonsils with exudate. The patient's pharynx was inflamed but without lesions, and the patient was without coughs or hoarseness. During an examination of the patient's neck, enlarged anterior cervical lymph nodes that were tender on palpation were noted. Posterior cervical nodes were non-palpable, and the patient did not note any tenderness when this provider attempted to palpate the posterior cervical nodes. No masses or unusual pulsations were noted on examination of the patient's neck. S1 and 2 heart sounds were normal. The patient's pulse was regular and had a regular rate and rhythm, and no heart murmurs were noted on exam. The patient's costovertebral angle was normal with symmetrical expansion, and no dyspnea, adventitious breath sounds, or cough were noted. The patient, no splenomegaly, hepatomegaly, or tenderness were noted on examination of the patient's abdomen, and he was without axillary or inguinal node abnormalities. The patient reported no tenderness on palpation of his back or scapular region, and no mental status abnormalities were noticed during the physical exam. A number of differential diagnoses were identified in relation to the patient's history and symptoms, including those noted on this slide. Pertinent positives supporting the diagnosis of a common cold include irritated throat, headache, and malaise. Confounding findings relevant to that diagnosis would be the lack of nasal stuffiness, red irritated nasal mucosa, nasal discharge, sneezing, or hoarseness. Pertinent positives supporting the diagnosis of tonsillitis include the presence of sore throat, pharyngeal edema, enlarged tonsils, tonsillar exudate, malaise. Pertinent positives supporting a diagnosis of viral pharyngitis include the presence of sore throat, pharyngeal edema, enlarged tonsils, and tonsillar exudate. Confounding findings related to a possible diagnosis of viral pharyngitis would include the lack of conjunctivitis, ear pain, sinus discomfort, nasal congestion, ulcerative stomatitis, cough, hoarseness, diarrhea, the vesicles or ulcers on the palms of the hand and soles of the feet, and viral rash. Pertinent positives supporting the diagnosis of bacterial pharyngitis include cervical lymphadenopathy, fever greater than 102, sore throat, palatal petechiae, pharyngeal edema, enlarged tonsils, tonsillar exudate, headache, abdominal pain, and malaise. Pertinent negatives supporting the diagnosis of bacterial pharyngitis include the absence of conjunctivitis, nasal congestion, hoarseness, cough, diarrhea, sandpaper, or viral rash. Pertinent positives and negatives supporting a diagnosis of bacterial pharyngitis also support the diagnosis of a streptococcal pharyngitis. One confounding finding on examination of this patient with regard to a diagnosis of streptococcal pharyngitis is the absence of a sandpaper rash. Pertinent positives supporting the diagnosis of infectious mononucleosis include the presence of fever, pharyngitis, anterior lymphadenopathy, malaise, headache, palatal petechiae, tonsillitis, and abdominal pain. Confounding findings relevant to a potential diagnosis of infectious mononucleosis include the absence of chills, sweats, fatigue, posterior cervical lymphadenopathy, splenomegaly, mild hepatomegaly, and nausea. Pertinent positives supporting a diagnosis of influenza include the sudden onset of high fever, pharyngitis, headache, malaise, and cervical lymphadenopathy. And findings that would be confounding with relation to a diagnosis of influenza include the absence of cough, rhinorrhea, irritated mucous membranes, myalgias, and arthralgias. This patient was diagnosed with streptococcal pharyngitis, and this diagnosis and that of streptococcal tonsillitis are overlapping. The definition for streptococcal pharyngitis is a pharyngitis caused by group A beta hemolytic streptococcus, and the pathogen responsible is Streptococcus pyogenes. Related pathophysiology includes a streptococcal invasion of body defenses, adherence of the streptococci to the pharynx, colonization, and then secretion of toxins that damage patient tissues. Risk factors associated with a diagnosis of streptococcal pharyngitis include age, specifically individuals who are between 5 and 15 years of age, although this diagnosis is common in all ages. An additional risk factor associated with a diagnosis of streptococcal pharyngitis is exposure, especially to infected others within the previous 2 weeks and during periods of outbreak. Winter and spring seasons are also risk factors, as well as the presence of crowded living situations. No gender prevalence was noted with regard to risk factors identified for a streptococcal pharyngitis diagnosis. The prevalence of streptococcal pharyngitis with regard to patients presenting with acute pharyngitis is 20 to 30% in children and 5 to 15% in adults. Streptococcal pharyngitis tends to occur in clusters and is more common in the winter and early spring, and accounts for 1 to 2% of outpatient visits. Common symptoms associated with the diagnosis of streptococcal pharyngitis include tonsillitis and viral, bacterial, and streptococcal pharyngitis. The modified center score criteria were applied to this patient's symptomology, and a score of 4 was obtained. Based on the patient's score, a rapid antigen detection test was done with positive findings, and so the patient was diagnosed with streptococcal pharyngitis, which again is the diagnosis that overlaps with streptococcal tonsillitis. This patient was prescribed penicillin B potassium 500 milligrams to be taken by mouth twice daily for 10 days. And this patient was also, the use of ibuprofen was also recommended to this patient to address his symptoms. And the recommendation was to take 200 to 400 milligrams by mouth every 4 to 6 hours, with a maximum dose not to exceed 1,200 milligrams in 24 hours. And the patient was also advised not to take the medication, or the patient would be advised not to take the medication for more than 10 days. No laboratory tests were recommended in relation to this diagnosis. Patient education would include attention to diagnosis, follow-up, and treatment. Specifically, the patient ideally would be informed that there are multiple causes for the presenting symptoms that he has, but that streptococcal pharyngitis is the identified cause in his case. The patient would also ideally be educated to, or informed that he might expect his fever anywhere between 101 and 104 to continue for 4 to 5 days, but that he could expect to see an improvement in his symptoms in the next 3 to 4 days, especially as he was engaging in treatment. Patient education would also include instructions to contact the provider if the patient did not receive any improvement, or if the patient was having difficulty handling secretions, if the patient was drooling, had a hot potato voice, had a toxic appearance, or had unilateral neck swelling. The patient ideally would also be educated about treatments associated with his diagnosis, including that penicillin is the first-line treatment to eradicate streptococcal pyogenes, infection with streptococcal pyogenes. The patient also would be taught that analgesics and antipyretics could be useful to him, as well as supportive care, and that NSAIDs have been proven to be more effective than acetaminophen in treating pharyngitis. The patient would need to know that he might experience adverse effects in relation to his use of penicillin, including black hairy tongue, diarrhea, epigastric discomfort, nausea, and vomiting. The patient also would ideally be taught that he might experience marked diarrhea, hypersensitivity, rash, urticaria, meaning hives, superinfection such as a candida infection, fever, vomiting, erythema, dermatitis, angioedema, and seizures, and would be taught what each of these terms means. Additionally, the patient would be taught that adverse effects associated with ibuprofen use can include constipation, diarrhea, indigestion, nausea, and headache, as well as upper respiratory infections, and that the patient could also experience gastrointestinal bleeding, which could be reflected as blood in the stool, chest pain, skin irregularities, and rash. And the patient would be taught to contact his provider if he experienced any of the symptoms that are noted on this slide in red. The provider for this patient would ideally consider consulting, collaborating, or referring the patient if, in the case of the presence of tonsillar edema, which was noted in this case, and also if airway obstruction was noted, paratonsillar abscess was present, or the patient was suffering with post-streptococcal glomerulonephritis. Follow-up for this patient is usually, there's not typically follow-up necessary with a patient with this diagnosis, but reassessment can be made if the patient is not improving, in which case a provider may want to reconsider his or her original diagnoses and consider the presence of possible complications. Additionally, providers could choose to do a post-treatment culture or a second rapid antigen diagnostic test, although this is not typically recommended, but there are cases where a provider may choose to do that, specifically if a patient, to ensure patient compliance, or if the patient has a personal history of rheumatic fever, develops streptococcal pharyngitis during a bout with rheumatic fever, or after an outbreak of streptococcal glomerulonephritis. Additionally, post-treatment cultures or rapid strep tests could be done during a follow-up visit if the patient has a family history of recurrent rheumatic fever. Health promotion associated with this diagnosis include alcohol misuse screening, as well as screening for depression, high blood pressure, and HIV, as recommended by the United States Preventative Task Force Services. Disease prevention for this diagnosis would include avoiding contact with infected others, especially during outbreaks, attention to hand washing, particularly during cold weather months, and avoidance of bacterial transmission, specifically through the use of utensil and cup sharing. Prompt treatment can also prevent disease, particularly in those who have a family history of rheumatic fever. Additional disease prevention measures may include the use of probiotics that has level 3 evidence. Also, the use of interfering alpha streptococci may reduce incidence. Patients need to understand that they could have a recurrence of this particular condition, and that treatment with penicillin, even 9 days after the onset of a streptococcal pharyngitis infection, can reduce the incidence of rheumatic fever. Finally, patients need to know that routine testing and empiric treatment of asymptomatic family contacts and prophylactic treatment of siblings is not generally recommended. Treatment guidelines associated with this diagnosis include supportive care, such as sucking on hard candies, lozenges, warm saltwater gargles, soft foods, cool liquids, fluids, and a toothbrush exchange when treatment is completed, humidification, the use of oral sprays and rinses, analgesics and antipyretics. Treatment guidelines recommend the use of penicillin, cephalosporins, clindamycins, and macrolides to treat this condition, as well as the use of acetaminophen or NSAIDs. Steroids are not recommended by treatment guidelines, nor is tonsillectomy typically recommended. And guidelines do recommend educating patients particularly about the course of the disease. As you can see, I've included a prescription here for a diagnostic test for a rapid strep based on the symptoms of sore throat, fever, and tonsillar exudate. And I have also included a prescription for penicillin V potassium, 500 milligrams, 1 tablet to be taken by mouth twice a day for 10 days with a 20 tablet count prescription provided here. And you can see my references here. And I don't see you. I don't know if you can see me, but that about wraps up this presentation. So with that, I will close. Thank you.